We are recording today's session. We have a lot of people that are interested, but of course this time doesn't work for everyone, and we have folks around the globe. I know I did get at least one person in the UK that said they would really love to watch, but it's a little late. So we're going to go ahead and get started. And again, this is being recorded. So just if you've not attended one of the doc talks that I host before, or just as a reminder for anyone that has, everyone has been set to be mute on today's session. I would ask that you please respectfully stay muted. We're really going to try to learn and focus on Dr. Nadig's presentation today and make sure we have a good recording so that we can use this in the future for everyone to refer back to. The way that it works is he will do his presentation, and then you can put any questions that you have in the chat feature here in Zoom. So go ahead and ask questions in the chat feature here in the Zoom. And then at the end, we'll have time for Q&A. So I will read questions and we will do the Q&A. So with that, I want to just take a second to introduce our speaker. So tonight we are so privileged to have Dr. Satish Nadig from Northwestern University. And he is going to talk to us about a very exciting topic that's near and dear to my heart, which is reimagining transplantation oncology. So he's going to talk to us about the advancements that Northwestern is making, and specifically with a trial that he has running to make transplant easier to achieve for metastatic colorectal cancer patients with liver metastases. So this is a topic, again, that's near and dear to a lot of us in Colon Town. We have an entire neighborhood dedicated to liver transplantation. We have quite a few patients that have undergone this procedure and quite a few that are looking at it now. So we are really excited to have you and learn from you. And the floor is yours. And once again, thank you so much on behalf of all of our patients and caregivers. We're really thankful for your time and expertise. So the floor is yours.
Thank you so much, and it's really a pleasure to speak with you all today. Honestly, transplant is a true passion of mine, and I've been involved in transplantation for many, many years. And the root of the word passion actually means, it comes from passos, and it means to suffer. So the question is, what are you willing to suffer for? And it's been a really joyful suffering for me of transplantation, and most importantly, the suffering it takes to actually get transplant to the next era. And I'm going to talk about that fact that we're really squarely in that next era now. I do have a disclosure. I am a chief medical advisor to a company, but I'm not going to talk about any of that today. So transplant had its beginnings, basically every culture out there has some root in transplantation, meaning that every culture, every mythology that you hear about has some root in transferring tissues from one creature to another, for example. And this really came to fruition in the winter of 1954, when Joseph Murray transplanted a kidney from one healthy twin into a twin that had kidney failure. And that really sparked our field. And it really was just a little over 70 years ago. I always often joke that, my own father is older than the field of transplantation. Between the 1950s and the 1980s, we had to figure out a way to dampen the immune system so people could accept the organs that they were getting. And we got really good at that. And that was really sort of the era of immunosuppression. These medications that kind of go through your whole body to suppress your immune response to keep you from rejecting the organ. Because we got so good at that, we were able to proselytize the field a little bit. We needed to spread the field. In order to get organs to go across state lines, we had to create preservation solutions. And that happened in the 1980s and 1990s, which is the era of preservation. Then we got just better at doing the operation. We started doing split livers, for example, or minimally invasive donor nephrectomies, where we take the donor kidney out laparoscopically. And we call that the era of technique. And largely for a long time, everything sort of stopped. We still use the anti-rejection medications that were developed in the 1970s, and the same preservation solutions that were developed in the 1980s, and largely the same techniques that were developed in the early 2000s and 1990s. But what's really interesting is that we now have the advent of nanotherapy and robotics and machine perfusion and gene editing and xenotransplantation. You hear a lot about it on the news now, and we're squarely in the next era of transplantation, which I like to call the era of technology. And one of the themes that we have at Northwestern is we really want to be on the forefront of this era of technology. And I'm going to talk to you a little bit today about transplantation in general, what technology means for transplantation, and how do we apply that to newer forms of transplant or newer fields in transplant like transplant oncology. Well, let's start from the beginning. The organs have to come from somewhere. So donors are really a scarce resource, and there's really not that many donors out there. Although last year we had the most number of donors in really the history of transplant, and of course in the last 4 or 5 years. So we had about 12,000 donors out there, about 10,000, 11,000 deceased donors. But the problem is this: there's still a significant number of people on the list that died without a liver transplant or without an organ transplant. So there still is a discrepancy between those organs that are available and the patients that need them. So out of about 15,000 donors that are available, some decide that, families decide, or the patients had decided previously they don't want to be donors. Some organs are recovered, but not able to be transplanted. The majority are transplanted. Some are not recovered at all because the donor does not progress to donation. And some are recovered for transplant, but not transplanted. Now, this group is very interesting. Why are they not transplanted? Often because of biopsy findings or long warm ischemic time, or they're just not a good recipient for this particular organ. And I think that that's where the potential intervention can be, to really increase that number of donors that come to fruition, able to save a life. So what does that really mean? Well, we can use these organs, and we call them marginal organs, and there's some criteria for them. What constitutes a marginal organ? Well, one thing is there's two types of donors out there. One type that has brain death, and that's why they're considered a donor, and they pass away from brain death, but their heart's still beating and beating blood to their livers. Or we have something called donors after cardiac death, where the heart stops, and then we have to recover the organ. And by the act of their heart stopping, we call that a marginal organ. Or, for example, the organ can have a lot of fat content in it. We call that macrosteatosis. Or the donors can just come from older people or elderly donors. Some other sort of relatively marginal organs are ones that have hepatitis C that we know we can eradicate with drugs we have today. Donors that have been in the ICU for a long period of time or have high vasopressor requirements to keep their blood pressure up that can affect the blood flow to the liver. So these are all sort of marginal organs. So if we take the donors after cardiac death, for example, if you look at Illinois versus the US in 2024, so these numbers here, we're actually increasing the numbers of donors after cardiac death or circulatory death that we use amongst and beyond those that are in the nation, and amongst and beyond those that are donors after brain death. So we're trying to increase the numbers that we use of the donors after cardiac death. But in Illinois, they constitute about 37% of donors, still way less than the number of brain dead donors that are out there. If you take obesity, we have a real problem in this country. We have an increasing epidemic of obesity amongst our population, and that just reflects in macrosteatosis, or the amount of fat content that's in a liver. So our projection for 2030 is about 50% of livers of patients out there will have obesity, and a quarter of patients will have severe obesity. That's a BMI over 35. If you look at this figure of the United States on the right, you see the prevalence of overall obesity in the yellow, and that's just increasing. And as you go up in the color scale to the deep red or purple, that's just more obese. And by 2030, the entire country is either obese or more obese in that blue. And if you look at the right, green is sort of 0% of severe obesity, and yellow and orange is the prevalence of severe obesity, and the entire country is really going in that direction, which is really scary, and it's going to really portend our use of organs, and makes us think about how we can use these organs a little bit better. So, what are the consequences of using these marginal organs? Well, the most devastating consequence is the patient doesn't survive the operation. But more commonly, what we see is what we call early allograft dysfunction, or the organ sputters after being transplanted. It doesn't work right away out of the gates. You have an increase in what we call biliary complications, or the bile duct has complications because the bile duct derives its blood supply from the artery, and that it can get compromised with some of these marginal organs. Of course, these patients are sicker. They stay in the hospital longer, so there's increased cost and a prolonged length of stay. And eventually, the organ and the patient don't have long-term survival, which sort of defeats the purpose. The other thing is that these extended criteria or marginal organs are more susceptible to something called ischemia reperfusion injury, meaning they're out of the body without blood flow for a period of time. They get hooked up to a blood supply. They all of a sudden have a blood supply again, and that causes a particular type of injury called ischemia reperfusion injury that can cause complications. The most common complication of that is something we call ischemic cholangiopathy. And what that is you see this beaded appearance of the bile ducts when they should look nice, like nice long tubes. You get this sort of beaded appearance, and these bile ducts kind of go away, and then eventually the organ gets scarred down and dies. Well, at Northwestern, we've been trying to utilize various technologies to make these marginal organs work, and work like brain dead donors or living donors, which is really the gold standard. And if you look at our mix of organ transplants, we are one of the larger organ transplant programs in the country. And we do a pretty even split of DCD donors and brain dead donors. And we have a large volume living donor program as well, to offer different types of organs to the patients that we have that are in need of organ transplants. And how do we do it? Well, we utilize various technologies. So every program has a thesis. Most all programs, underpinning of their thesis is quality. There's no program out there saying they want to do a shoddy job. Everybody wants to do a good job. So quality has to be an underpinning of it. Our thesis amongst quality is innovation. We think that we don't want to grow for growth's sake. We want to grow by using innovation plus quality and be a destination center. So I often tell people Northwestern can't just be a direction. It's got to be a destination center for transplant. People have to come here because we can offer something to them that maybe they can't get somewhere else. And one of the ways we do that is through machine perfusion. Well, what is that? Well, the current standard of care, and what has been the standard of care since the 1960s, when the first liver transplant was done, is cold storage. The organ comes out of a donor. It goes into a preservation solution. Remember, preservation solutions that were developed in the 1980s. It goes into an igloo or Coleman cooler, travels across the country or across state lines. We take it out of the cooler, we take the liver out and sew it in. That's the standard of care. But now we have these newer technologies called machine perfusion, where we can put the organ on a machine perfusion pump and either pump blood through it at normal temperatures, and it's just functioning outside the body. It's a little bit like science fiction. You see this organ pumped blood through it, and it's making bile outside of the body, or something called hypothermic preservation, where we pump it in a cold solution and we pump the cold solution through it. Now, there are so many devices now that are available for this. So, for example, an Organox Mitra, which is a normothermic blood pump perfusion machine, or Transmedics, which pumps blood through it and flies out. You fly it out to the organ. In Organox, you bring the organ back and put it on the pump here at the hospital. We have a liver assist transporter, for example, that does both normothermic machine perfusion and hypothermic machine perfusion. A LifePort liver transporter that is hypothermic or cold preservation pumped through the liver, and something called a VitaSmart or a hypothermic perfusion solution or perfusion pump as well. So based on the temperature at the time of perfusion is how we identify these pumps. So it's either hypothermic, subnormothermic, or normothermic. And hypothermic, it can restore oxygen to these organs without activating the metabolism because it's cold. It still slows the metabolism down. And but the problem is that if the device dysfunctions, it actually is not that big of a deal because it just goes back into standard cold storage like you would have in a cooler. There's a low risk of infection. The problem here is that you can't really give too many interventions because a lot of drugs and medications we give have to be at a normal temperature. On the other hand, you have normothermic preservation, where the liver is metabolically active. It's at a normal temperature. It can clear lactate. It can produce bile. The problem, however, if it has dysfunction, the graft is now warm and it's not getting blood pumped through it, so you have a potential graft loss. There is a potential increased risk of infection, but if you need to give a therapeutic, you could potentially do that because it's at that normal temperature. So there's potential for intervention, which sets it up for the future as well. So there are many trials that have been around this, and I'm going to just kind of go through them pretty quickly here. So the normothermic machine perfusion trial in Europe was the very first one of these, and this is very new, 2018, where we did a randomized control trial of normothermic preservation in liver transplantation. And I'll point to the top line, which look at the discard rate. In the control setting, a quarter of livers were not being used, which is 11.7% in normothermic machine perfusion. And even if we were using more livers and they had a longer preservation time, 12 hours versus 7 hours and 45 minutes, you still had a much better reperfusion syndrome, meaning when we give the liver back, the patient doesn't get unstable. When we give the blood back, the patient doesn't get unstable. You had much less early allograft dysfunction at 10% versus 30%. And these biliary and arterial strictures were much less in the machine perfusion before, as opposed to the control, although not significant. And our graft survival and patient survival was just in line with the control. So the patients and the grafts were doing well with a very similar length of stay. So the US decided that they were going to do a similar trial. They were going to do it on the Transmedics pump, and this is called the PROTECT trial. And what you found was very similar things. There are incidents of early allograft dysfunction right after preservation, right after reperfusion, was much less than the control. On top of that, you looked at the post-transplant pathology. You really had very little inflammation in these livers when they were pumped, as opposed to the controls. And when you looked at the biliary complications, one of the most common complications after liver transplantation, much less in the pumped livers in the dark green as opposed to the control livers. And you saw graft survival was very similar without early allograft dysfunction. So there was a New England Journal paper that came out that looked at machine perfusion and looked at that in the hypothermic setting or the cold storage setting. And what they wanted to define is what was the amount of bile duct dysfunction or through a cholangiography by two different treatment methods. Is the hepatic artery open? And they looked at different types of modalities of looking at the bile ducts through magnetic resonance or imaging or ERCP. And when they looked at the results, they saw that hypothermic machine perfusion performed much better than the controls when looking at the non-anastomotic strictures or strictures that happen outside of where we sewed it into, which was really exciting that this hypothermic machine perfusion could work even better than the control. And just like in normothermic machine perfusion, you had much less post-reperfusion syndrome, much less of that early allograft dysfunction, and again, that biliary complication rate was less as well. And so this was called the pilot trial or a phase 3 clinical trial. And Northwestern was proud to say we're one of the 8 centers in the United States as part of this trial, which is ongoing right now. And these are for sort of the geographic distribution of these 8 centers that are ongoing right now with these hypothermic machine perfusion. Our early data shows that we do have fewer biliary complications in when we pump oxygen through these cold preservation solutions using this hypothermic technology. So what does it look like at Northwestern? Well, we already are using transmedics. I already showed you our data from the hypothermic machine perfusion and the LifePort transporter. The liver assist is mostly used in Europe, but now we started doing this as a research protocol in 2019. In 2021, we started the FDA trial for the LifePort liver transporter, and we just started in 2023 our transmedics normothermic perfusion pump. This was all going to be applicable to the transplant oncology world, as you'll see as we move through the discussion. But in 2025, in July, we're going to be starting with Organox, and we're part of the phase 3 trial for this liver assist transporter, as I described. So why are these things really important? Well, I'll give you some non-oncology reasons. Take some case examples. We had a 54-year-old gentleman who had cirrhosis. He had a very high MELD score of 34. And we had a donor that was very fatty donor at 30% macrosteatosis. And we put it on our hypothermic machine perfusion pump, and it looked great. It looked like a normal liver right after reperfusion. And this is the liver right after reperfusion. And if you look at the liver function tests, they normalized within hours after transplantation. Within just a few days, they were down to normal. Or what about challenging cases? We had a patient with severe polycystic liver disease, and this is the liver coming out of the patient. And it takes a lot of time to take these livers out. We can't keep the liver sitting there for a long period of time. So we often use that time period to pump the liver. And in this case, we, in fact, in order, because of room, we had to split the liver down in the middle, and we were able to pump this liver on the pump after we've split it, the first one done in the US, and then transplanted the split liver. And this is the arterial waveforms of it, looked perfect in this patient, just like it belonged. And it was the first time we were able to split a liver and put it on a machine perfusion pump. So why am I telling you all these things that have nothing to do with cancer? Because I will subject to you that these are technologies that we should be applying to cancer. So let's talk about transplant oncology. So the most common reasons that we transplant for cancer are, number one, most common is hepatocellular carcinoma. Secondly, intrahepatic cholangiocarcinoma and some neuroendocrine tumors. But what's becoming more and more real is the idea of transplanting for colorectal metastasis. So this is just an example of a 54-year-old woman with stage 4 colorectal cancer and had no other options. But we see this, and we look at the data, and we see that with transplant, we can get upwards of 60 to 80% survival, much better than chemotherapy alone. So we look to trials that have been done that many of you know, SECA-1 and SECA-2 trials, these Norwegian trials that help define the role for transplant in these patients. SECA-1 was about 60% survival over chemotherapy alone. A more stringent criteria was SECA-2 that got us up to about 80% survival. Now, let's just take that in combination with, or in contrast to chemotherapy alone, where you have a 5-year survival rate of 10%. We've got to be thinking transplant when we have no other options. Of course, when a cancer is resectable, resection is the answer. But liver transplant for unresectable colorectal liver metastasis is just becoming more and more frequent in the US. It's one of the top reasons of cancer deaths now in the US. And I often say it's often becoming a disease of the young. There's various protocols out there, but generally speaking, and what we stick to as well, is obviously disease limited to the liver. We look at mutations that help portend a better prognosis, not a complete contraindication, but a relative contraindication. Usually a CEA that's less than 80, or we look at a trend at a CEA. We look at the standard uptake value on PET scan, and we make sure that the primary is out and patients have undergone a first-line treatment. We know by SECA-2 that more restricted patient selection gives us better 3 and 5 year survival rates. But here's the problem. lots of centers in the US are not transplanting for colorectal metastasis. In fact, I will tell you that there are oncologists out there today that don't even know that we're transplanting livers for colorectal metastasis. We've got to get the word out there. And unfortunately, and because of the case I'm going to show you, and one of the reasons that this happened was one of the cases I'm going to show you today, United Network of Organ Sharing never had a MELD exception point for patients that have colorectal mets. Now it's 15, but a lot of it was due to some of the work that we did here at Northwestern. So what does that mean? These patients have normal liver function. The liver is just riddled with cancer. So they're low on the allocation list. So they're not pulling these even marginal organs. So they rely on living donation due to this allocation policy. And really modest exception points. That just limits the volume of the organs that we can offer to them. So here's the problem. There's limited access to transplants for patients with colorectal liver metastasis. So we thought, could we use a potential solution? In Oslo, there was a technique called the rapid technique to expand access to deceased donor grafts, where we stage the transplant. We take half of the cancerous liver out, transplant a small portion of a deceased donor liver, let it grow in the patient, and then remove the rest of the transplant. It relies on liver regeneration, the physiology of the liver, to use a graft that's typically too small for a recipient. The other thing is it relies on altruism. The person that the liver is donated to has to be willing to give up a small portion of that liver. But let me tell you a story. About 6 months ago, a little over 6 months ago, we had a patient that came into our clinic. He, salt of the earth guy, family man, had really no other options and had colorectal liver metastasis. He was status post neoadjuvant chemotherapy. He'd already had a sigmoid colectomy. Surgical oncologists had worked hard to try to do wedge resections and ablations and chemotherapy, but he had persistent disease. He was isolated to the liver, but he was unresectable. He was a healthy guy. He loved to camp, had 2 kids, and he was on systemic chemotherapy, and he was suffering on systemic chemotherapy. So in 2021, he had undergone his colonoscopy because of change in his bowel habits, and it showed the sigmoid adenocarcinoma. He underwent 10 cycles of neoadjuvant chemotherapy, and in 2022, he had a sigmoid colectomy and multiple wedge resections, sort of with this idea that potentially he could be set up for a right hepatectomy to get rid of his cancer. So he continued with adjuvant chemotherapy and even had a portal vein embolization to his right side in order to have extended right hepatectomy so that that left side could grow. But eventually, he wasn't getting the growth of his left side. His cancer was not receding with the chemotherapy, and he was referred for a transplant evaluation. He continued local therapy, tried looking for a living donor, tried for months to look for a living donor, and he could not find a suitable living donor. And eventually what happened was he was listed for a deceased donor liver transplant in March of 2024, but his MELD score was 6. So he was in the clinic. He had gone through months of trying to find a living donor. We couldn't get an offer for him. He was suffering on chemotherapy, and he said, I've resigned to hospice, but you cannot let me die. You have to think of something that has a potential option for me. So we thought 6 months later, why not rapid as a pathway to transplant? It had not been done in the US before for various reasons. And we think that, it would have been very hard to do it because we were not able to even pull organs for him. So just to reiterate, rapid was where you have a full deceased donor liver. The recipient, we take a small portion, the left lateral segment, we take the larger right trisegmentectomy and give it to recipient 1 that has actually been offered this liver in the first place and who agrees to give up a small portion of it. On recipient 2 who has colorectal mets, we remove half of their cancerous liver, leaving half in place. The smaller piece of the donor liver gets sewn into the patient. So part of it is cancerous, part of it is the new liver. We wait 2 weeks, wait for that small piece to grow to sustain the body, and we go back and remove the remainder of the cancer, rendering him cancer free. That's the theory behind it. And colorectal met patients are often suited to this because they have preserved liver function, which reduces their risk of this post-hepatectomy liver failure. So we explained this to him. We explained this to a patient that we had gotten a liver offer for, which was a 45-year-old DCD liver, considered marginal. We put it on a machine perfusion pump. It was not a fatty liver. And we decided we were going to split it on the machine perfusion pump. Now, in order to practice for this, I had actually gotten the organ procurement organization to give me 2 livers that were discarded for transplant. I got the operating room to block off an operating room. I got the company that does the machine perfusion to come to Chicago, and we practiced. And the first one didn't go very well. It was kind of difficult, kind of cumbersome. The second discarded human liver that we used, we kind of got the system down, and we're like, okay, we're ready to do this. We finally got an offer from that day. We went to the person it was allocated to, who graciously and without us even finishing the sentence, had a brother who died of colorectal cancer. So very quickly said, yes, I'm absolutely okay donating the left lateral segment to this person she'd never met. So she strongly wished to proceed. We took our patient to the operating room. And while we were taking out the left lobe of the cancerous liver, we were splitting the left lateral segment off of the normal donated liver on the machine perfusion pump. The patient that received the larger trisegmentectomy, the larger portion of the liver, did fine. We then sewed in the smaller section, the left lateral section, to our patient with colorectal liver metastasis, closed him up, waited 2 weeks, and the liver grew from about 397 grams to about 800 grams. And you'll never see this picture again in your life, probably. But this is the liver being split on the pump. This is the normal liver in him, and this is the cancerous liver. And we just separate it with abdominal fat. And 2 weeks later, it grew to almost full size. This is the cancerous liver. This is the normal liver. We took him back to the operating room. We completed the oncologic operation, the completion hepatectomy. He was discharged 6 days later. This slide was made at 4 months follow-up, but today I can tell you he's over 6 months cancer-free. He was going to hospice, and today he's over 6 months cancer-free with no radiographic signs of disease recurrence, no detectable cell-free DNA, and no CEA level or normal CEA level. So this was remarkable. And although the rapid technique has been used sparingly internationally, no one in the US had ever done this, and nobody globally had ever split a liver on a machine perfusion pump using a DCD liver and transplanted a patient. So we were the first rapid technique in the US, first split liver on normothermic machine perfusion in the US, but combined the first globally. We thought we can't just do this for one person. This relies on altruism. Colorectal met patients are well suited for this. And although it's resource intensive and highly coordinated, we have the ability to do this. So we started a trial, colorectal metastasis to liver extraction with auxiliary transplant and delayed resection, our CLEAR registry, which we're actively recruiting for now. And this is real time, hot off the press. We evaluated 5 patients last week that came from all over the country who really had no other options and no living donors. So we're really excited to bring all of those things together, the innovation of transplant, the technology of machine perfusion, the use of marginal organs, and a dedicated team to be able to do this. And this is our patient now. This is all public knowledge. We had a press conference, and you may have seen him on the news recently, but can you imagine he was going to hospice 6 months ago? And this is my partner, Zach Deach. He and I did this together. And this is our full team. And you can see some of the news articles with this. So with that, I just want to say thank you. This is my email address and some QR codes in the beautiful city of Chicago, and I'm happy to answer any questions you might have, and I'll stop my share at this point.
Thank you so much. I only see one question as of now, and I learned a lot doing this. So this is really exciting, and I'm really looking forward to sharing this information in Colon Town with our patients. And that story is pretty spectacular. So our question is about thank you for explaining all of this. Could you explain why KRAS mutation is often excluded? I've read about co-occurring KRAS and TP53 mutations being at higher risk for recurrence after liver resection, but not for KRAS mutated alone.
Yeah, so it's just a relative contraindication. It's sort of a prognostic factor of 5-year survival, 3 and 5-year survival, and we don't use it solely as a contraindication. We bring that in as a data point amongst everything on whether someone's going to portend a good prognosis or not. And we really take a lot of our cues from our oncology team as well. So I also want to apologize, but not apologize. I put a lot of transplant in the beginning of it, especially with machine perfusion, but I think it's important to understand the background of this, of what leads to the trial that we have going and what leads to sort of the application of this to transplant oncology.
I don't think you should apologize. I think that's really important. I think that especially for patients, we get patients all the time. So it's an education, re-education for people to understand. So I think that's really important for everyone to understand. Also, your point about how many physicians and GIs that live in the colorectal cancer space, but still don't know about transplant. It's really important for patients to know this stuff so that they can help educate, the providers, to be honest. Someone's asking if you can put your email address back up. And we also have another question.
Should I just put it in the chat? I can just put it in the chat.
Yeah, you can put it in the chat. Mm-hmm.
Okay.
And I have another question for you, which is, I know MELD scores started recently with colorectal patients. Do you think the number will increase in the future?
Yeah. Let me tell you the story about that. So UNOS had not, we had petitioned UNOS, and Northwestern has a strong voice with UNOS because we're a large volume program, and we had petitioned UNOS to increase MELD scores and have a MELD exception point like they do for cholangiocarcinoma and hepatocellular carcinoma for colorectal mets, and we just weren't getting anywhere. It was just stuck. And I'm certainly not taking credit for this, and Northwestern's not taking credit for this. I'm just giving you a timeline. So what happened was we did this case on our patient here that I showed you at the end, and then we then went back to UNOS and said, oh, by the way, we did the first of these cases, and this patient did not get liver offers, and we're going to have to do this because we have to tell UNOS, okay, we're going to have to do this. We're going forward with this case. And by the way, he doesn't have exception points. 1 week after he was transplanted, UNOS came out with a memo that colorectal met patients are going to have a MELD score of 15. So, I think that there was a lot there. That wasn't just coincidence. Do I think it's going to increase? I do think it's going to increase. And I think it's going to increase as more and more centers come online with doing colorectal met transplants. We just don't have as many centers doing it, and the larger the volume of centers that do it, the more voice that we have for UNOS.
Thank you. We have additional questions here in the chat. Actually, they're coming in. So we have a patient that's saying, I have multiple metastases in every section of my liver. Would transplant possibly be an option for me? I would love for you to answer that and maybe get some context around what makes a transplant patient with colorectal liver metastases. And maybe also as you're working up patients for your trial purposes, if there's anything that's different or anything.
Yeah. So multiple metastasis is sort of where we live. Having a met or a resectable met, you wouldn't want to be transplanted. You would just be resected. It's multiple metastasis. Number of lobes doesn't matter. It's multiple metastasis that's confined to the liver, and that's our wheelhouse. That's where we live because that's where transplant becomes an option. Does that answer the question?
Yes, we know that other centers in the U.S. have qualifications such as a CEA under 80 and
Yes.
things of that nature.
Yeah.
Could you speak a little bit to
Yeah.
some of the requirements that you have for this?
Yeah, so CEA under 80, but it's not that's an absolute number. Even if the trend is going that way, we will consider that with our oncology. We do this closely with our oncologists, and we have a tumor board and all those things. We do look at your metabolic uptake on SUV. We look at your ctDNA levels and which way they're going on chemo. So those are some of, but we don't, there's no strong or hard contraindications. We kind of take it case by case and see if we can offer that. I'll tell you that the reason I say that is because we are also right in we did. I don't know if many people know this, but we did the first. Our group, Northwestern, did the first lung transplant for lung cancer, and so we are actively willing to do lung mets of colorectal cancer, and would do double lung liver transplant for colorectal cancer. So I'm very hesitant to give hard and fast contraindications because that's not who we are. We usually just take it case by case, and we give people the options when options don't exist. So we are the only center in America that would do a double lung liver transplant for lung cancer, and that too colorectal met too. So we have 2 trials ongoing right now. Not only our CLEAR trial, but we have something called the DREAM trial, which is lung transplants for lung cancer. We can combine those two. So.
It's a lot of hope for our patient set. Does the number of lobes involved impact eligibility for this trial?
No.
That's an right. We have then another patient said, thank you. It's an up and coming as a new method of treatment. I'm currently one of 3 at my center. My liver surgeon is leading the way, but she works closely with the oncologist. He told me today he's still learning about transplant.
Yeah, I'm very open to sharing knowledge. I don't think we should, anything that one person does is just a thing they do. It's not a program. So if anybody wants to reach out to us to learn more about our program, I'm more than happy. We have people coming from all over the country that come and visit our program to learn about various things. And in turn, I actually go and visit other programs and learn about what they're doing. So email, Zoom calls. If oncologists, want to talk to our oncologists, we're more than happy to collaborate and share knowledge. This is about treating patients. This is not about a particular program. So the more patients we can get on board with their lives saved through these technologies, the better. So we're more than happy to liaise with your own physicians. If you want to just tell them, give them my email address, I'm more than happy to share this knowledge.
Thank you. Next question was, how long would you need to be on chemo before you can do a transplant?
Yeah, so typically about at least 6 weeks.
You answer quickly, which is great. I have dogs, so that's why I keep muting. I'm like, oh, I don't want any barking. And so one of our patients said, thank you so much for your time and information. Truly exciting for the future of metastatic colorectal cancer. Liver mets when no other option is there. Thank you for pushing for better future for all of us. We do have one other question. With a deceased donor, I assume you can't be off chemo before transplant. How risky is that?
Yeah, so you can, because remember, this organ is offered to someone else on the list. So what we would have, you'd have the off the chemo, maybe not full 6 weeks, and so we can kind of adjust accordingly, but you're off for a period of time, a few weeks, let's say. And then if we get an offer, which we do 4 to 6 liver transplants a week. So if we get an offer that's the same blood group as you, we assess it to see if it would be a good liver for you, for example. Then we go to that recipient that it was offered to and ask them, will they be willing to give up a quarter? So remember, this deceased donor liver is not offered to you. It's offered to someone else. And think about all the offers that we're getting for other people on the list. I hope that answers the question. It's a little complicated, but.
That's the last question that I see. So I don't know if we're going to have any more, but let's see. Yes, actually, there's one more here. Do you typically require patients to have been on chemo for a certain amount of time before you would allow them to be eligible for a transplant, living donor or deceased?
Yeah, typically 6 months, but again, we take it case by case, but typically 6 months.
Perfect. All right. So a lot of the questions that I had that I was going to ask, because I wanted them recorded, you've answered here from other people's questions. But I'm probably going to have to reach out to you again to see if maybe we could get your lung transplant colleague there at Northwestern to come on and maybe talk to us about what he's doing in that arena as well.
Absolutely, yeah. That'd be great.
Yeah. Well,